Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today, our topic of discussion is about macular neovascularization and its association in different clinical pathologies. For example, age-related macular degeneration, high myopia, and retinal vein occlusions. To present the talk and educate us, we have requested today and invited Prof. Enrico Borelli from University of Turin. Prof. Enrico has extensive experience in teaching medical retina. He has got almost 200 international publications to his credit, and he is considered an authority on OCT angiography. We want to thank him for accepting our invitation and giving us time to educate our audience on this challenging topic, especially macular neovascularization type 3. So without further delay, I request Prof. Enrico to present his talk.
Thank you. Thanks for, it's always an honor for me to be part of this YouTube channel. And so thank you again for the opportunity. I will speak about type 3 macular neovascularization. And so we know that AMD may be classified into different stages, and the late AMD may be characterized by the presence of a neovascularization or geographic atrophy. Type 3 macular neovascularization is a type of neovascular AMD and may be characterized by different features. So we will start with the history of type 3 macular neovascularization, just to remind everyone that this was first described in 1992. There was a change in the terminology in 1996. It was named retinal angiomatous proliferation in the 2001, and finally the name was changed again to type 3 macular neovascularization, which is the current name actually in 2008. We know that in neovascular AMD there are different types of neovascularization, and type 1 and type 2 neovascularization are characterized by the development of new vessels from the choroid, while type 3 macular neovascularization has new vessels coming from the retinal vessels. The prevalence of type 3 neovascularization is high. If we use only fluorescein angiography, the prevalence is almost 30% of all cases of neovascular AMD. But if we use even structural OCT, the prevalence is even higher. So this is a common type of neovascularization in patients with neovascular AMD. When we have a patient with neovascular AMD, it's always important to make a diagnosis of type 3 macular neovascularization. Using fundus photography, usually we are able to see the neovascularization with associated some an hemorrhage, some exudates, a PD, a pigment epithelium detachment. And in these cases, we may want to use fluorescein angiography to confirm the diagnosis, as in the presence of type 3 macular neovascularization, usually we can be able to see the retinal vessels dipping toward the RPE with some leakage and pooling. And in this case, you can see the late leakage. So in order to further improve our ability to make a diagnosis of type 3 macular neovascularization, we may want to also use ICG. Using ICG, it is quite easy to detect the presence of new vessels coming from the retinal vessels. And it is also common to see a late leakage. I'm going to show you the late images in this case. There is some leakage in the mid phases. And if we look at the late phases, the leakage is even more evident with also a fluorescent hot spot, as in this case. However, as I mentioned previously, in the presence of a type 3 macular neovascularization, OCT and OCTA may even improve our ability to make a correct diagnosis. And we know that structural OCT is a very useful device technology to investigate and to visualize all the different retinal layers. And OCTA, using OCTA, we may also be able to differentiate the retinal vessels at the different depths, and also the choriocapillaris may be investigated using this technology. This is a three-dimensional visualization of the retinal vessels in patients, in normal patients. In the presence of type 3 macular neovascularization, structural OCT usually demonstrates a retina thickening with associated intraretinal fluid and in an intraretinal hyperreflective lesion with also a deflection of the outer plexiform layer. And also a drusenoid PD or also a serous PD may be associated in these cases. Using OCTA, it is quite common to detect the presence of a flow signal within the hyperreflective lesion, which is the type 3 macular neovascularization. So if you have the suspect of a type 3 macular neovascularization, you may want to use a structural OCT showing the presence of an hyperreflective lesion in the outer retina, and usually some flow is detected within this hyperreflective lesion using OCTA. There is also a classification of type 3 macular neovascularization. This is the radial and normal conditions. However, in the presence of AMD, new vessels may arise from the deep vascular complex without any evidence of exudation. This is a non-exudative type 3 macular neovascularization. These new vessels may grow over time, may exudate, usually in the very beginning of the disease. Intraretinal fluid may be visualized. Intraretinal fluid may increase over time, and finally, patients with type 3 macular neovascularization may be also characterized by the accumulation of subretinal and subarachnoid fluid. So the staging of type 3 macular neovascularization is dependent on the localization of the type 3 macular neovascularization when the type 3 macular, when new vessels are located within the neural retina. This is stage 1 type 3 MNV. When these new vessels reach the RP, we may have a stage 2 or stage 3 macular neovascularization, type 3 macular neovascularization. So there are some risk factors for the development of type 3 macular neovascularization, including age. Females are usually more commonly affected by type 3 MNV, and also Caucasian are more commonly affected. Another important risk factor is the presence of type 3 macular neovascularization in the fellow eye. In these cases, 40% of patients develop type 3 MNV in the fellow eye within 1 year, 56% within 2 years, and almost all patients within 3 years after the development of unilateral type 3 macular neovascularization. So there are other risk factors, including choroidal hypoperfusion, the presence of reticular pseudodrusen. Reticular pseudodrusen are common in patients with AMD, and these are easily visualized using a blue light, and they may also be visualized using structural OCT as they appear as subretinal drusenoid deposits. There are different stages of reticular pseudodrusen, and they are completely different as compared with drusen in terms of location. Reticular pseudodrusen are located above the RPE and are mainly located in the periphovia, and also in terms of composition. Reticular pseudodrusen are common also in other disorders, or they are not unique of AMD. They may also affect patients with angioid streaks. And reticular pseudodrusen are a very common risk factor for type 3 macular neovascularization. Another one is choroidal hypoperfusion. We know that the choriocapillaris may be affected in patients with AMD, and maybe we may want to study the choroid using structural OCT. And one of the most important factor associated with the development of reticular pseudodrusen is the hypoperfusion of the choriocapillaris and a thinning of the choroid. So the choroidal hypoperfusion is another main driver that may eventually lead to the development of type 3 macular neovascularization. This is again to remind everyone that reticular pseudodrusen are common in patients with AMD and they are a recognized risk factor for the development of type 3 macular neovascularization. And also choroidal hypoperfusion. These are some studies showing this. So again, old female patients are more commonly affected by type 3 macular neovascularization, especially those patients with choroidal hypoperfusion and the presence of reticular pseudodrusen. Finally, let's talk about the outcome of these patients. We know that anti-VEGF therapy has improved the visual outcome in patients with neovascular AMD. However, in the presence of type 3 macular neovascularization, the outcome is usually worse, especially in those patients with subretinal or sub-RP fluid. And another important aspect to highlight in the type 3 macular neovascularization setting is that these patients commonly develop macular atrophy. Macular atrophy is a terrible complication in patients with neovascular AMD, affecting visual acuity, and those patients with type 3 macular neovascularization is the main risk factor. So, in conclusion, type 3 macular neovascularization is common in patients with neovascular AMD. All the female patients with reticular pseudodrusen are at higher risk of developing type 3 MNV. And finally, the development of macular atrophy is a common complication in type 3 MNV. So the outcome of patients with type 3 macular neovascularization is usually worse. Thank you.
Thank you, Prof. Enrico. It was a really very good discussion. You explained in detail the aspects and very important topic and challenging, especially for ophthalmologists. Prof, I just want to ask we know that you are an authority on OCT angiography. So how do you differentiate? You're the best person to answer this, that early and intermediate, this MNB type 3 in AMD, how do you differentiate on OCT angiography?
So OCT angiography is very helpful in patients with AMD. The differentiation between early and intermediate AMD is mainly based on structural OCT. However, we may want to use OCTA as patients with early or intermediate AMD are usually characterized by different degrees of choriocapillaris hypoperfusion. So patients with intermediate AMD usually have a greater hypoperfusion as compared to those with early AMD. However, OCTA is more helpful when we want to make a differential diagnosis between early and intermediate AMD with late AMD. So OCTA is very helpful in the presence of pigment epithelium detachment, especially those PDs with a shallow, irregular RPE. In this case, we may really want to use OCTA to detect the presence of a neovascularization. In this case, we may also want to follow the patients in a different way.
Right. Prof, one thing more, sometimes we encounter patients who have got bilateral disease and it is asymmetrical. What is your approach in management of these asymmetrically bilateral eyes involved?
So that's a great question. It is very common to see patients with symmetrical disease. And with bilateral disease, this may be symmetrical or asymmetrical. It is also common to see patients with asymmetrical disease, as the first affected eye is usually worse in terms of outcome. The treatment is usually start later in the disease. So, in the presence of bilateral disease, regardless if this is symmetrical or asymmetrical, I always wanted to start my treatment with a loading dose of anti-VEGF injections. And then I usually treat my patients with treat and extend regimen. However, in the presence of bilateral disease, the treat and extend regimen may be difficult to be followed. And so it is not uncommon that I treat patients with bilateral disease with a fixed regimen. I usually prefer to avoid to treat patients with an as needed treatment, as it's quite common to have relapses, especially in patients with type 3 MNV.
Right, Prof. Prof, one thing more that when we use the OCT angiography, how usually do you differentiate that the choriocapillaris flow is because of type 3 or it is because of this PCV, Prof?
So OCT angiography is very important to differentiate type 3 macular neovascularization from PCV. As you mentioned, the choriocapillaris has a role in this differentiation, as patients with type 3 MNV usually are characterized by a greater hypoperfusion as compared with those with PCV. Using OCTA, you may visualize the choriocapillaris, and regions with flavoids are larger or are greater in number as compared with patients with the PCV. However, OCTA is very helpful to differentiate the neovascularization, even because you can clearly see the neovascularization. In the presence of type 3 MNV, the neovascularization is within the retina, so you can see flow within the neuroretina. In the presence of PCV, you may see flow just below the RP, and usually you can clearly visualize a round or oval shaped lesion with some flow inside, which is the polyp actually.
Very well explained, Prof. One thing more, Prof, we are also managing the patients with this anti-VEGFs, but I want to ask you, what is your experience about the use of intravitreal steroids, especially when there is inflammation and fibrosis element? What time, what stage you believe that it should be introduced?
So that's a great question. I assume and I really trust that there is some inflammation in patients with neovascular MD, and the inflammation may be even greater in the presence of neovascular MD, and maybe in the presence of type 3 macular neovascularization. Type 3 macular neovascularization may be very commonly complicated by fibrosis, which is a terrible complication in patients with type 3 macular neovascularization. Because you have fibrosis, you may want to use some drugs to reduce the inflammation, as fibrosis is for sure even associated with inflammation. I don't have experience with the use of intravitreal steroids in patients with type 3 macular neovascularization. However, I believe that the new anti-VEGF drugs with also some anti-inflammatory pathway may be the game changer for these patients.
Right, Prof. Well, Prof, I think you have explained this challenging topic in detail and answered the clinically related questions. And I hope this will be very beneficial for our audience and their clinical practice. I know, Prof, you are extremely busy with your research, patients, management, and even your administrative duties. But whenever we invite you and request you, you always gives us time and for our audience and me myself and on the behalf of my audience, we are extremely thankful for your this acceptance of invitation and educating our audience. Thank you, Prof. It
Thank
was
you.
really
Thank you.
worth attending your lecture and learning from you.
Thank you. My pleasure. Thank you.